So welcome back from the break. I'm Mary Pasquinelli. For those who don't know me, I am a nurse practitioner and I'm the director of the lung screening program at the University of Illinois in Chicago. And I'm really excited that this is kind of our final session, session 6, Meaningful Screening Conversations, Coaching about all health information from a screening chest CT. And over the last day or two, we have learned so much. A lot of AI and coronary artery calcification and emphysema, and how do we partner everything that we have learned about what we can see on a chest CT to improve outcomes. But we're going to take this all back and bring it back to what's the most important, and that's our patient. Keeping the patients in the center of this information and the center of this dialogue to be sure that what we're doing and the research around it and the policy around it gets to that patient, so the right decisions are being made for that patient. So I'm really excited that we have a great team to discuss this next session. Alexis Paulson is a nurse practitioner of the centralized lung screening program at Vanderbilt. Dr. Michael Gieske, he's the director of the lung screening program at a large hospital system, and Vicki Beckler, who was very instrumental in running some very large programs, and now is on the industry side where she is really trying to roll this out nationally. So we have a lot of levels, but each one of them really is keeping the patient center. So with that, if we could go to the next slide. So I just really have one or two slides just to kind of set the stage before we bring our panelists on. And as people who know me, I've used this slide in the past, and I always use that low-dose CT results as a teachable moment. Now, most of us know that, we're really looking at those lung nodules, finding that lung cancer early over on the left side, that was actually an early stage lung cancer that was diagnosed in our program. But there's other things that can be found on the chest CT, emphysema and coronary artery calcification. And those are the big three that we've been really talking about. And Dr. Yankelevitz is also talking about, we can also see osteoporosis and maybe even adding more information, the information that we can get on that chest CT in order to discuss these results with our patients in order to improve outcomes. I want to share two examples with patients I've seen in the last couple months. One was about 2 months ago, a 55-year-old woman who came in to have a shared decision-making lung screening visit with me. And she felt like that her health is very good. She was currently smoking and was not willing to stop. She goes, I feel fine. I'm smoking, but I don't want to stop. My doctor did want me to go through this lung scan, and I'm willing to have the lung scan. So we had a conversation around that, talked about her risk, and she had her lung screening scan. She came back to see me a couple weeks later for the results. And I sit down and I talked to her that we really didn't find any suspicious nodules, some very small ones, and we discussed what a nodule was. And I said, but you do have quite a bit of emphysema on your scan. And she goes, I was told I had emphysema before, and I did look back, and she had a scan many years ago when there did show some emphysema, or it said emphysema on the report. She goes, I know I have emphysema, but I feel fine. I'm not short of breath, and my smoking really isn't bothering me. And I said, let's see what your lungs are telling you. Let's pull up the scan. We'll go through this. And then I started showing her the areas of emphysema, those holes in her lungs that are there. And I even showed her from where they were years ago, and they had grown. And she kind of got quiet. She started crying. And she said, I didn't really understand what emphysema meant. No one explained it to me. And I said, well, we're here now, and we're going to talk about it. And through our discussion about, we can't fix the damage that has been done, but moving forward, we can help her to prevent the damage from getting any worse. And then she was very open to stop smoking. We started her on varenicline, and she successfully quit about 6 weeks later. So it really kind of goes to show you the importance of delivering the message about how important it is and how we can act. She's 55 years old. She has a whole long life ahead of her. And we can possibly, hopefully, change some of the future that she could have had with poor outcomes if she didn't stop smoking. The other patient I wanted to highlight is a 62-year-old male who came to see me. He had not been engaged in healthcare for many years. He ended up getting primary care at one of our FQHCs. The doctor ordered a lung screening and he came to see me. Now, the primary care doctor did run a 10-year risk assessment for coronary artery disease and said he was very high risk and wanted to put him on a statin. And he said, I was a heavy smoker and I quit 2 years ago. I really don't want medications. And the PCP did have that conversation with him, and he still was very reluctant to start a statin. He came to see me and we pulled up the scans and I showed him what that coronary artery calcification looked like. It was moderate to severe. And we discussed where it was and the vessels and the heart. And through that, we had a really great discussion about the findings on the CT scan. And he at that time says, I think I do need to be on that statin. He came up with that with coaching with the primary care doctor and with me following up. I connected with the primary care doctor and then he started on a statin. So with that, I feel that if we only look at lung screening for lung cancer and lung nodules, we're going to miss a huge opportunity to really improve health with our patients. Almost so many of our patients are at super high risk for pulmonary disease, coronary artery calcifications, and heart disease, along with a lot of other incidental findings outside of the top big 3 that we can find on CT. We can go to the next slide. So with that, can we do better with coaching? I feel we can, and I have really, through the quantitative imaging workshop over the last couple of years, where Dr. Molshine is like, I was thinking of just lung screening, and he's like, there's more we can do, there's more we can do. And it really has kind of changed my practice with health coaching. So can we do better with health coaching? I think we can. I think our smoking cessation rates can be better. I think we can be much improved with our adherence rates to lung screening and addressing those comorbidities, the COPD and cardiovascular disease, promoting lifestyle modification to improve overall health. We know tobacco affects every cell in their bodies, not just lung cancer or 15 different types of cancers, but coronary artery disease, stroke, diabetes, hypertension. And supporting mental health and emotional well-being. My patients live in very stressful communities on the south and west side of Chicago. And sometimes just addressing the emotional well-being of our patients is incredibly important. I had a patient not too long ago, and I worked so hard with her to help her stop smoking. And she was just so stressed. And when she tells me about her life, I'm like, oh, I can see how incredibly stressful her life was. But I did get her a social worker and she did get into therapy. And when I saw her next, I asked her, I said, how are you doing with the smoking cessation? She goes, I quit smoking. Oh. And I'm feeling like I did my job. I got her, on the patches and we talked about she didn't want to do varenicline. Got her on the patches. She goes, no, I got counseling and therapy to work on my stresses. And that helped me quit smoking. So sometimes it's not the obvious, like I give you this intervention, that's going to work. It's really looking at our patient individually to understand where they are and what their needs are. And then addressing stigma, the language that we use, the non-judgmental viewpoints that we need to take with our patients to be sure that they feel comfortable, particularly with health coaching, because we want to be sure that we're addressing where they are and not where we are. And then reducing health disparities. A lot of people in this room know I'm about health disparities. We need to be sure that all patients, no matter what walks of life or what type of insurance or how they access care, gets the right care. And it's not just the people who goes to the high-end doctors or have the high-end insurance plans where they have more bells and whistles that we need to help all of our patients. So with that, I want to go to our panel. We can go to the next slide. And if each one of you just can take a few minutes and introduce yourself and tell us a little bit about you and your program, and then we'll open it up to questions. Alexis, if we can start with you.
Hi, I'm Alexis Paulson, coming to you live from Nashville. I am the clinical coordinator of the Vanderbilt Lung Screening Program. I think a lot of you know Kim Sandler, who is the director of our program. I started in 2005 at the inception of our standard of care program after Pierre Massillon had passed the torch over to us after all of the NLST data collection. So he was a big part of the development of our program, and so we have been working on it since 2015 and trying to develop what makes sense with our population, with our region, with our health system. And I was actually brought on from our breast center. So I have a history in women's health and had been working on the radiology side of the breast center, helping with image guiding biopsies. And as lung cancer screening was coming online, they needed a nurse practitioner to help with the required shared decision-making visits. So I was tasked with assisting with that at first. And then as the program solidified, they needed a coordinator to help design the program. And given my experience in health cancer screenings, I kind of fell into that, into this world. And it has been a really interesting process, especially as I have gotten to know other navigators and program directors all over the country, all over the world, how different every program is. Ours is based in the radiology department. So we take referrals from primary care providers, pulmonologists, et cetera, provide centralized care in terms of a shared decision-making consultation for every patient, navigate them through the imaging and the results, and then navigate them into interventional pulm or whatever their results dictate. And then we track them annually. And as I learned through my my other cancer screening experience, how to stay on patients and get them back in annually. That kind of became my number one, my personalized task to myself, is to figure out how to get these patients back every year. Because as we know, one scan is good, but those annual follow-ups are where we do the most good in terms of lung cancer detection. And so we partner with the pulmonary department. We partner with primary care physicians and communicate. We kind of act as a liaison between all three departments. We do have a tumor board, and but it is a kind of unique program design from what I can tell in terms of talking to other institutions and program directors. Is that kind of answer your question?
Thank you. Dr. Gieske, if you could introduce yourself and tell us a little bit about your program.
Sure. Thanks, Mary and all, for this opportunity. I'm a family medicine physician by trade, and I've been working with our lung cancer screening program for about 8 years. I was asked to be the primary care representative on our thoracic oncology disease management team back in 2016, and had never heard of a low-dose CT lung cancer screen at the time. As you know, the AAFP didn't really endorse lung cancer screening until April of 2021. So I learned in the first time of my long career of about 36 years at the time that we had something that could make a difference in the lives of our patients at risk for lung cancer. We started rolling it out. We went on a little bit of a road show, myself and the chief thoracic surgeon at the time, and visited the primary care sites, started educating them. And about lung cancer screening and the difference it can make. And we've grown a very busy program. We're on track to maybe do 50,000 screens here shortly. And we've found over 440 stage 1 lung cancer. So extremely rewarding work. It's been a good ride. We've been doing this for a fair amount of time, and we're starting to see the changes that happen in the evolution of a program. As you've been in a lung cancer screening program for a decade or more, you really start getting folks back, and you start to see less and less stage 3 and stage 4s. And each year, the stage we find in stage 1 seems to be increasing. We're tracking about 72% in stage 1 right now. So making a big difference and trying to get the word out. A lot of it's, as you know, is communication and education. Oh, by the way, I'm with St. Elizabeth Healthcare. I don't think I mentioned that, Northern Kentucky and Southeast Indiana.
And you have many different hospitals within that hospital umbrella, correct?
Yeah, it's all St. Elizabeth Healthcare. We have 6 hospitals and 2 imaging centers. Serve about 400,000 patients.
And Vicki Beckler.
Sure. I'm Vicki Beckler, and a little bit about my background and why I'm here at the table. I guess I've been in this space since 2006. I joined Wellstar Health System and was onboarded and tasked with starting a research study as part of the ILCAP trial in Atlanta, and built that program into a pretty high screening program, and was there until 2018. Wellstar Health System has 11 hospitals. They screen at 17 different imaging sites. When we built and started the program, we designed it as a central model. It's a hub and spoke. They're all things. It's very standardized. All lung cancer screenings filter through the program. All follow-up exams go through the program. The program has the autonomy to put the orders in and schedule the patients in advance. It has a very high adherence rate. They screen around 10,000 patients a year. I'm told they will surpass 10,000 this year. And so that's kind of a little bit about my history there. Although I'm no longer there at Wellstar, I transitioned into industry in 2018, where I spent 4.5 years literally working with many centers across the country, building out lung cancer screening, as well as IPN programs, and even can help with multidisciplinary care clinics. And in 2022, I transitioned to AstraZeneca, where I lead the U.S. Lung Ambition Initiative. So my primary focus is national, looking to help drive and increase screening uptake, looking to help create program infrastructure, looking at novel, innovative ways to find lung cancer earlier. And I do want to say that the comments and opinions and insights that I share today during this session are my own and do not necessarily reflect AstraZeneca, and they're based on my clinical experience that I just shared.
Thank you. So I'm going to start a couple questions, and we'll start with Alexis. So Alexis, you run the centralized lung screening program, and I know that you give the results to your patients getting scanned, or the individuals getting scanned. When a screening CT reveals emphysema and coronary artery disease along with nodules, how do you approach the complexity of these results with your patients, and what are your key priorities in guiding patients through these findings?
Right. So I didn't mention that since the pandemic, we have also been on telehealth service for all of our patients. So we actually do them by phone, the shared decision-making visits in advance, and the results are given by phone. And so that has kind of impacted our workflow a little bit in terms of how, I would say, how high touch our program used to be in terms of giving results in person. And so what I try to do to mitigate that a little bit is to do a lot of front end education about the harms of tobacco and the potential outcomes of the scan in terms of coronary artery calcification and emphysema, COPD. So we talk about that a lot on the front end. And then when we call with the results, we do go over these findings. But since we're based in radiology, we have really tasked the referring providers, the pulmonary providers and the primary care providers with managing these abnormalities in terms of either medications or referrals for additional testing. And so I would say that it's a great opportunity. It's a great teaching moment, both on the front end and on the back end, to talk about these issues. But in considering it more in our preliminary discussions about this conversation, it really has sort of got me thinking that that our program should probably be taking additional steps in following up with these patients. When we have really significant incidental findings, the P findings, like a kidney finding or an aneurysm finding, we obviously track all of those to diagnosis and treatment, and confirm that quality care is being provided, even if we're not the ones providing it. And I'm kind of starting to believe that we should also be tasked with managing and at least tracking these coronary findings and emphysematous findings as well.
Do you think that primary care is receptive to, if you took in more like health coaching within the lung screening program? Do you think that they would be receptive to that? Is this kind of how I would love to see it, as more of, this is a multidisciplinary where the patient is the center and we're all working together? Or do you think they would not be receptive to that?
Yeah, that's the part that that we're going to have to kind of work out, because as we grow throughout the region, we've added more and more facilities, imaging facilities. We're up to 8 imaging facilities in Middle Tennessee. And as we grow, we are obviously impacting other practices throughout the region that we don't have such a close relationship that we do to our Nashville physicians, who do have a lot of trust in our care and give us a lot of autonomy to take care of the patients and their findings. That's part of the conversation that would definitely be interesting, because I will say there are a lot of providers who've been ordering lung cancer, just outpatient lung cancer screenings at their local outpatient imaging center. A lot of those are not even accredited as centers of excellence, and not necessarily reporting their data to ACR, that sort of thing. So there's been a lot of reteaching in terms of who's eligible for lung cancer screening, and best practices for providing it in a lot of these areas. And so that whole dynamic of stepping in and providing more contact with their patients, as well as redirecting their attention to the best ways to provide lung cancer screening. It is a little bit of a tricky conversation sometimes. And so I would say that the majority of providers in our system are very receptive to that. But as we grow, it's going to take some time and some relationship building to gain trust across the board.
Great, thank you. Dr. Gieske, you as a primary care physician, I know that you've done a lot of health coaching throughout your years as a physician. So tell me a little bit more about when a low-dose CT does reveal emphysema and other coronary artery disease, and how do you integrate the coaching within those visits? But then also, just not you as a primary care doctor, you're the director of the whole system now, and now you're talking to a lot of the primary care doctors. I want to see what your thoughts are on this. If we switch this just from lung screening to thoracic imaging and all the things that we can diagnose and see on the scan to improve outcomes. Wanted to see what your thoughts are as a primary care doctor, and then also as the director of the lung screening program at St. Elizabeth.
Yeah, sure, Mary. So a lot of the coaching and counseling happen in 2 places or two phases, you know, originally when you order the low dose CT lung cancer screen, and then when you see the patient back to review the results. And it seems like increasingly there's an emphasis on changing the paradigm of lung cancer screening to lung health screening or CT chest screening. And at first I had a little reluctance and pause with that, because we don't call a mammogram a breast health screen. And it's just, there's a part of me that wonders if we're adding to the stigma of lung cancer screening. But at the same time, we see so much when we do a CT screen of the chest, and we get these reports back, and yeah, we do see whether they have emphysema or coronary artery calcifications, osteoporosis, aneurysms, and all those things are part of a report. And we really emphasize with our providers how important it is to read that whole report. You know, one of the greatest travesties, and we've all seen it, is a patient's told your CT screen was normal, and meaning that there was no nodule there. But then the patient, you know, they of course have access to their patient portals now. What's severe coronary artery calcifications mean, or severe emphysema? So it's really important that we address those things. And so I put out a quarterly newsletter each quarter, and we talk about lots of things. But it's a standard part of that report to emphasize how important it is to read the complete report. And I've started kind of changing in my mind how we refer to lung cancer screens, you know, make it a lung health screen or a CT chest screening. And I see some value in that. That all kind of started actually over in the UK with the mobile programs in Leeds and Manchester. And they really started that whole lung health process. And you know, they actually do spirometry, pulmonary function testing, along with a lung cancer screen, oftentimes too, do the smoking cessation counseling. And I think it's definitely worth weaving into our program as well, to a certain degree.
And then how do you think with the workflows would go with I know that you have all the primary care doctors mainly ordering it, but if it was kind of a hybrid program where nurse practitioners with lung screening and primary care doctors, how do you think that if we integrated those systems, how do you think primary care doctors would be receptive, or just wanted to think along those workflows?
Yeah, I can't hardly imagine the primary care doc would have a big issue with a nurse practitioner, a PA doing the counseling with their patient. It takes some of the burden off the primary care providers sometimes. We're a very decentralized program when it comes to the ordering part. You know, any provider can order the low dose CT, do the shared decision making. I think that the mandated shared decision making adds a lot of complexity to lung cancer screening, and this whole question, are you a hybrid, or are you a decentralized or centralized program? I wonder really a lot, once that mandate goes away, which I suspect it will eventually, what that's going to do to change the approach to lung cancer screening. It's going to simplify it to some degree.
Do you think there'll be still a role for nurse practitioner-led programs?
Yeah, I think so. I mean, I think that the education that nurse practitioners are able to provide is certainly a value.
Vicki, I'm going to transition over to you. And from your perspective in industry, how are new technologies and innovations, I know that you're always kind of looking at different things, contribute to health coaching in patients that have been diagnosed with lung disease or conditions following up after a low dose CT? And what tools are available, or that you know that are coming down the pipeline to help providers do tailored coaching for low dose CT testing screening?
That's a great question. And as we learned yesterday, that is a huge gap. And I feel it's, you know, it's emerging, but there's an opportunity for us here. And I want to kind of touching on that a little bit, you know, because it focuses on education, like what can we do? And then I'm going to transition to the industry side for a moment. But just on the clinical side, education, and one of the things at Wellstar that we did early on is we embedded in the CT report, there is education into the CT report on coronary calcium and emphysema. And we actually worked with, and I forget the name, the gentleman, the physician from Israel that helped do IL-CAPS correlation with the calcium. That's it. He helped us refine the language that we have into every single CT report, and patients read that. And it helped immensely because then they're not looking, going, I've got extensive calcification. What does this mean? It tells them what it means, and it tells them what the recommendations are. Anyway, so going back to industry, it's interesting. I think we're in a really a great position to help identify the various challenges that exist amongst all the healthcare organizations. And we're in a unique position to kind of see under the hood some of the emerging technology that's being developed. And, it offers an opportunity to how can we come together in this space to better help to validate some of this, help connect these, help to link up where the need is amongst the different centers. So it's promising, I think, what's coming, but we're still not there yet. And when I say we, I don't mean just industry, I mean just we as in the whole lung cancer screening space, and even outside of that, the whole healthcare space. I think there are some tumor sites that are further along than others. And I'll give you an example of this is I know that in the colorectal space, for example, based on some of my previous experience, there's some software and technologies that are existing where surgeons are operating, patients are going home, and they're going home, and from home, their wound is being monitored, their temp is being monitored, their weight, their blood glucose or blood pressure. And then on the other end, there's an opportunity. This data gets pushed back into the provider's office, and back there you've got a clinician that's able to look and see, oh, so this patient spiked a temp, this blood pressure is going down, and it offers an opportunity to circumvent a potential ER visit, to be able to go in and provide care sooner and to have better outcomes. So that's kind of the surgery side of things, but on the education side of lung cancer screening, I think there's some opportunities with apps and things like that. And I often say, if I was still in clinical practice, every one of my lung cancer screening patients, I wouldn't change anything that WellStar's doing today that I had implemented, but I would augment it. I would record a YouTube video. And whenever you make that screening appointment, of course, that you're going to get that message via text, and there's going to be my YouTube video. You click it. Every patient would then have a standardized message that they read. And it would say, if you still have questions or would like to talk to a clinician, press here, and that message would come to me, and we would be able to pick them up and telephone them.
I love that idea.
Yeah.
Great innovation.
God, I'd love to see you do it. I'd like to support
You
you.
never know about me. Yes. And I'm going to talk about that in a moment.
And I think there's opportunities with that, even with the results.
Absolutely. So let's talk a little bit more about the results. So individuals undergoing lung cancer screening, what do you think they want to know about their results? They can see everything, and I have to say, at our institution, our letters that we send out through Epic are horrible. In fact, we learned about a large language model yesterday that I would love to trial at our institution, where it gives really personalized information about what is on that scan. So it kind of reads the report and puts it in clear language for patients. But what do you think that they want to know? I have some patients that are like looking at 2 millimeter nodules and wanting to know, what does this mean? And what does that mean? And what does atelectasis mean? And other ones that are just, they just want to know, am I okay? So what do you think? I'm just putting this out to all 3 of you. What do you think that the patients want to know?
I think that's a great question. I definitely have a lot of patients who come in kind of expecting a full lung health check, asking, a lot of people say, are you going to be able to see how black my lungs are from my smoking? Are you going to be able to see how much damage there is? That sort of thing, which I think is really interesting. And then there are a lot of people who just kind of view this as an extra check on their checklist from their doctor of all the things they're supposed to do, and they don't have a lot of interest in the results as long as their doctor says they're fine. But you're right, and I also have a lot of patients. Sometimes my longest follow-up conversations are on normal results, because there are people who have a question about every single line of their report, which is great. So yeah, it's extremely variable. We serve urban, suburban, and rural communities, very different populations of people throughout Middle Tennessee, different education levels, different health literacy levels. And yeah, so standardizing some sort of way to communicate with thousands of people about what lung cancer screening can do for them and what their results mean is a bit tricky, for sure.
Are your letters kind of standard letters like ours are?
Yes, so our letters, they basically say, your lung cancer screening. So we call every abnormality result to go over in detail, rather than sending a letter. So our normal standard letter is, your lung cancer screening did not show any signs for lung cancer. If there were additional findings, you may hear from your referring provider, your primary care provider, with additional details or instructions for follow-up testing. I think we also say in there the best way to prevent lung cancer is tobacco abstinence, and that sort of communication is included there as well. But we don't get a lot of I don't get a ton of follow-up questions on our normal results, but occasionally there are those people who have a question about every line.
And how about the mild, moderate emphysema,
Oh, yeah.
mild, moderate coronary artery disease? How do you are those in a letter for if they had no lung nodules?
No, we do not include that in the letter. That is communicated to the referring provider, and we ask for them to follow up with the patients with their recommendations. Because a lot of those are known findings already as well. They're already on a statin, they're already on a baby aspirin, they're already in pulmonary care for their emphysema. So so I think also to kind of avoid over communicating known findings and causing additional concern with the patients, we kind of task that back to the PCP.
Dr. Gieske, what do you think patients want to know, and how are you doing at St. Elizabeth? Can you do better with personalized reporting or personalized information on that scan report?
Yeah, I think we're all coming from the same place far with the letters. Essentially, our patients are told it did not show anything suspicious for lung cancer, but there are other things that are found on your chest CT that your primary care provider will discuss with you if need be. But I think getting a formalized, standardized summary of their CT screen is a great idea. When I was up at Lung Rescue Life, I think that's where I saw Dr. Moran speak. And what they do is it was a pilot trial where if they saw coronary artery disease, they would actually include a picture, an axial picture of the chest CT, circle the area where the coronary artery calcifications were, and then sent that to the provider. And the provider said it was okay. Then within the next 2 weeks, they sent it to the patient. And I think that's very impactful when you see that visual image of coronary artery calcifications, or you describe the degree of emphysema or aneurysm. The patient, when they see those kind of things, their antennas are gonna go up anyway. You explain it to them in simple terms. I think that goes a long way. I think there's a certain fear of telling patients too much. And then, words like atelectasis and all these other big words that show up in reports too. Yeah, patients wonder what the heck does that mean? And then it ends up in your inbox. And I think as we get further along the way of technology and AI, we hopefully will have mechanisms that will answer those questions in an automated fashion, so the provider doesn't have to get involved. And that's coming. It's here. We're doing a little pilot work with that type of process already.
I would love for you to just mention the large language processing pilot that you're thinking of, and would love to get some feedback. I mean, that is like really personalized kind of health coaching.
We're very excited about this, and this really, I have to thank Rick for bringing that team together. Rick is creating an army of college students and now even high school students to work on this. I mean, it's just spectacular. And I suspect this is going to continue to grow. So this is a father and son team who are kind of adorable in a geeky sort of way that are working on this. And they made a wonderful presentation. It was the first time I've spoken with them a few times before, but we have this idea that we can make personalized reports and make even potentially start to make the reports personalized and then interactive. So what Vicki did X years ago, we can take it to the next generation now. I think, and people can start asking questions about what's in the report, maybe even put links directly into the report based on what the findings are, and have links going to YouTube videos.
Wouldn't that be awesome?
So I'm very excited about doing this. I asked Mary if she would work with us on this project, and I think this would be a great project to have you involved with as well. I think this is the future, and have this integrated into the whole system. One of the things that Rick has been working on with us is, we have this sort of open source management system that we're basically giving away. And we want to put all of this into the reports that are generated. Not only have the pertinent images appear on the report, and then have links in it. So this is kind of doable right now.
That would be awesome, because I was telling Mary at Wellstar from day one, patients they get their letter, the result letter, and they get their CT report. So a lot of education was spent so they don't get alarmed with what's in those results. And their letters would be very simple, but it worked really well. And it did work well having that information in there. Now everything's electronic. So having embedded links in there, imagine having that link. Now your report's here. Click and learn more about emphysema if you wanted more detailed information. And then also here's my summary video.
Yeah.
Whatever.
And it can do so much. And I mean, my patients, a lot of times they want the paper, they don't have technology as well as some of these other places.
Yeah.
Yeah, but getting that piece of paper with the report, and then also, this is what emphysema is, this is what we saw, this is what you can do. So you have some health coaching at a health literacy level at their level. And then also then you can follow up with their primary. You're already starting to prep things. Our patients never Google anything, very rarely. They're all getting it from their care team. So I think it would be a huge added benefit.
I have a few comments that I want to
Let me
say.
just add one more quick thing. There are hundreds of universities with computer scientists and others looking for really exciting projects. And if we were to take something like this, which doesn't require you to understand imaging and a whole bunch of other things, and we were to just offer a webinar to all of them to say, let's set up a few hackathons and let's tackle these fundamental issues. Say, conversing with somebody who's got some mental challenges or some other things. We could have literally 50 to 100 groups around the world working on this problem and accelerate this at a really rapid pace. So I recommend that, those who are interested get together. We talk about what we can do, what's advised.
That should be one of the outcomes of this meeting.
And you ask, how does industry help?
Right.
This is
How
a
does
perfect
industry help?
example,
Yeah.
live and in action of how industry can help with education, right?
I just
Yes.
feel like this is such
So
a gap.
It
such a
is
gap.
absolutely, it's a gap. And I want to just a few things before we end our session, because I know we're getting close to time. One, we have to be careful though when it comes to the technology, because we assume just because somebody, I'm going to use Epic as an example because it's predominantly what a lot of organizations are on. Just because someone has an active MyChart doesn't mean they access that information. So it's important that we are making sure that the patients are accessing that information. If that they're not, that we're leveraging the controls that exist within the EMRs to monitor, to say, oh, that patient's had that report for 3 days. They haven't opened it. Let's send the paper copy or whatever to make sure they are educated. The other thing you had asked earlier is, what do patients really want? And to me, what I have found, if I was summarizing it, really, they just want peace of mind. They want to know that they're okay. And that if there is something wrong, that they're in the right place, it's going to be taken care of. And then the other thing I wanted to address is something that we talked about earlier regarding the different models and programs that are out there. The reality is there are only two types of programs that exist. And this is from the world of Vicky. It is either a program managed model or it's a PCP managed model. And I always started at that was the basic where my starting point with any healthcare system that I was working with to build out a program. And what I mean by that is who is managing those results? If the center is wanting the primary care doctor to manage those findings, that workflow is going to look very different than a center like St. Elizabeth, where, you know, Mike, you manage all those results, right? So now within that from a
Well,
program managed so you
yeah, we don't really manage,
right?
we don't really manage the results. Once the screen's ordered, then it becomes very programmatic.
Okay, that's what I mean, though.
Yeah.
You're following those patients, you're gonna do the follow-up, you're gonna remind them to come back in. Will you do all of that, or does primary care do that?
Our program does the follow-up. It orders the
Okay,
follow-up.
that's what I
screen.
mean. So that's what I'm talking about. So in my categories, you would have a program managed model because
Yeah.
you manage those
Yes.
follow-up results. Versus there are centers out there that don't. They just get the results, send it to primary care and expect primary care to
Oh, sure.
manage them, put the orders in, get the patients back in. So it's like if you can start there, then you kind of build around it. The shared decision-making and all of that. Again, if it's PCP managed, it's already expected they're taking care of that. If it's program managed, well, you might have a pathway where the program can incorporate shared decision-making, but they may not. And to me, it's always best to leave that to primary care anyway. But anyway, that's what I wanted to just share.
Alexis, you were weighing in?
No,
or-
I was just raising my hand that yes, we manage. I didn't know if she was confused. Yeah, we manage our results and yeah, keep all of that internal.
Yes.
And I agree that we're talking about what they want to know, but I also have had patients that come see me and I tell them about the coronary artery calcification or the emphysema that had been on other scans and they said, I never knew that.
Oh, lots of the patients that I would see had no previous
So
knowledge.
this would be very important. I know,
Yes.
Dr. Mulshine.
Two concrete things. David told us yesterday that change over time is going to be the most important marker on
Change over time.
the reporting of change over time. You have a little bit of time now to sit down and figure out how to do this correctly, simply, effectively. And I would try to make that a focus because as screening matures and more people come back year after year after year after year, that's the goal.
Yeah.
Okay, so I would really try to cherish how you convey that. Number two, Mike, respectfully, you were talking about the energy that emerged in Manchester and stuff about lung health. And that arose after 20 years of coaching, where
Mhm.
we had worked with the Liverpool people who had a molecular epidemiology program in Liverpool Lung Project and setting up all these risk management things. And we said, okay, you can do epidemiology all day long. You got to do screening. And so we got to do screening. And then all of a sudden, screening went from the most disdained activity in medicine in the UK to it became a focus of regional competition. It was amazing.
Yeah. Yeah.
And it turned out these industrial centers all have massive, European leading lung tobacco exposure consequences. Okay. So you talked also about stigma. What we've got to do now is understand that stigma is kind of about respect. They don't feel respected. They're browbeaten. They did this to themselves and that to themselves. And it's very, very stark in England, at least it was 25 years ago. In any event, the whole concept of this pan-thoracic imaging or whatever components is actually about empowering the screening subject to be the architect of their own health. And us supportive teams help enable that. But this is about respect and empowerment. And so to me, a tagline is like, Chest CT is empowering. And it's about, you are not a victim, you are an active driver of your health. Can be,
Mhm.
whatever, has to be done sensitively and stuff like that. But I think this whole, what you saw in Manchester is that they internalized all this and they used it as a source of energy and positivity. And I think building on that kind of thing, all the stigma melts. It doesn't all happen overnight, but they're powerful. They have knowledge, they have data. They know that they can do this and they can do that, and they can do statins, they can do physical exercise,
Yep.
they can do diet, they can do stress. So I think we got to kind of build this in a very positive way, and it's a great opportunity.
I love it.
Agree, Jim. Yep.
Are there any other questions for our panel? I love the discussion and, you know, over the last day or two, my mind has been going, oh my God, this is so great. And I keep talking about the evolution of our little program at UI Health. But as we're adding to it and, you know, we are serving kind of really the tough to screen, you know, people are like, oh, minorities and low education and poor. I mean, those are people who usually don't get engaged in screening as much, and they want to be at the table. And I just think that adding more to help all of our patients, no matter where they are and their journey through lung screening, is going to be very important. And I'm looking very excited to working with our team. And Dr. Giesky and Alexis, if you want to join us, and Vicki, I know you're at a different level joining us. But it would be really great to have some thought leaders around this in the future.
Sure.
Absolutely.
So with that, we can close out this session, and I just want to say a sincere thanks to our panelists for helping us guide this really important conversation and keeping the center patient-centered. Thank you.
Great to see you all.
conversation.
Thank you, Mary.